Thank you. And I would be remiss without thanking Jeff again. I don't know if he's in here, but of course, this would not be possible without all of the great photos Jeff has taken over the past fair. Oh, there you are right there. I'm looking back there for you. Thank you so much. So we clearly continue to be grateful to those who started the symposium and those who have continued to help us continue this 10-year legacy. With that being said, we would like to present this year's, I don't think so. You want to do it or hold it at the end? Okay. So we're going to postpone the Vision Award to later in the program. So let's skip that. Okay. So with that, I will introduce our speaker. Yes? Okay. So we are honored to have with us this year Dr. Jonathan Woodson. Dr. Woodson leads Boston University's university-wide Institute for Health System Innovation and Policy. He is a Lars Anderson Professor in Management and Professor of the Practice at the Questrom School of Business and holds joint appointments as Professor of Surgery at the School of Medicine and Professor of Health Law, Policy, and Management at the School of Public Health. Notably, prior to this position, Dr. Woodson served from 2010 to 2016 as Assistant Secretary of Defense for the Health Affairs in the United States Department of Defense. He instructed me to keep it short. I will let you read the rest in the program. And without further ado, thank you so much.
Well, good afternoon, and thank you so much for the honor and privilege of delivering this address this afternoon. My job, as I understand, was to set the conceptual framework for this afternoon and this afternoon's panel, and you'll have a distinguished panel to discuss many of these issues as we go along. No disclosures. I like to begin a lot of my talks with this quote. It was attributed to Herophilus, who lived in 325 to 255 BC. But if you read the quote, it actually captures what we're all about and why we need to build better health within our society and encourage better health within individuals. Because it says, in essence, is that without health, we can't achieve our potential as individuals or as a society. So wisdom cannot reveal itself, art cannot manifest, strength cannot fight. So imagine, I'm sure everyone's had the flu, or those of you who have had family members who have had cancer, you understand how without health you really cannot be productive. Yet we know that health disparities exist, and I'm not going to go over this because this audience is very familiar, except to say that although life expectancy in general has increased, although it's declined a little bit in the last year or so with the opioid crisis, this progress has been uneven and adversely affected minority populations most severely. With an overabundance of cardiovascular disease, and as we'll talk about in a little bit, The issues related to infant mortality and maternal child health are quite significant. However, as mentioned, I led the military health system, and that's an unusual system in that it's an equal access system with a requirement to receive health care as a condition of employment. And actually, it evens out educational levels and income. So many of those social determinants of health are actually dealt with through that process of coming into the military and being in for a career. And so there have been some interesting studies that have been done in conjunction with the NIH, which have shown that in an equal access system where you're really addressing, maybe not intentionally up front in terms of a health focus, these other aspects, you can really make progress in terms of the disparities. So when you look at lung cancer, breast cancer, bladder cancer in this equal access system, the differences really shrink or even disappear. And in the case of breast cancer, there is clearly, even in African Americans, probably an advantage, of course, when compared to the civilian cohort. So there is promise, but it means that we've got to focus on the right things in terms of addressing health equities. And in the 21st century, we can't just do the same old thing and expect to get better results. That, in fact, what we've got to do is begin to look at new ways of delivering care and reimagine healthcare and what we want it to be in the future. Now, in 2001, at the National Academy of Science, then the Institute of Medicine, they came out with this report called Crossing the Chasm. And what they did is they described what the optimal system would look like. And I'm sure some of you are familiar with this. We want it to be safe. We want it to be effective, which means that we use evidence-based therapies consistently. Data today has shown that if you go into a healthcare system, particularly with a more complicated problem, you only have a 50% chance of receiving the right diagnosis initially and only a 50% chance of actually receiving evidence-based care. We want the system to be efficient, not waste resources, patient-centered, and you can translate this into personalized care because that'll take on a different meaning in the digital age. We want it to be equitable, meaning that when people need care, they can get it where it's best delivered. High performing and learning, meaning that we incorporate new knowledge and we function always on the basis of what best evidence is available. And then we want it to be connected. Now, in 2001, connected meant that we were connecting it across the continuum of care from hospital to community, which is important. In 2019 and beyond, it really is also about in the digital world and how this is going to change or should change how we see our connectivity. So the issue is that in today's world, there's data everywhere. The question is whether or not we have developed and we're learning to fly by the instruments. And this is really important. Do we have the instruments, and are we training the workforce and developing the systems to fly by the instruments so that we can change information into usable knowledge and create wisdom in the system, which means that we are constantly using the best evidence all the time to drive the best outcomes? And are we using new techniques such as advanced machine learning to improve the system of care and learn what we should do better? And does it match our workflow, and does it answer the needed questions? About a year ago or so, I wrote this small piece for the online Harvard Business Review journal, and really it reflected some experience I had years ago as a Army flight surgeon, in that I would go and do accident investigations, and what you would find that when human factors were involved, particularly pilots, the accident almost always clearly related to the fact that the pilot didn't trust their instruments and didn't follow their instruments. And this is probably how John F. Kennedy Jr. died. He was flying over water at night. There's this phenomenon that occurs that when you follow the curve of the earth, that you actually lose altitude and you can fly right into the water. The point of this paper was really that, in fact, medicine is so complicated today that we cannot rely on just what we retain between our two ears as individuals, that we've got to be connected in different ways and leverage digital systems to actually improve the care that we deliver. So we're on the verge, if not in the midst of this digital disruption in healthcare, and we've been working with some folks over at the business school on this concept of the digital health matrix. And basically it says that every industry is becoming digital, and even in medicine, if we didn't want to be influenced by the digital world, if we wanted to work in the analog world, which we try to desperately all the time, that it's not going to work because we're going to be influenced by outside actors coming into the health space, and we'll see evidence of this in a minute. And this is going to reform the way we do business. We can see it from the customer base because the smartphone came out in 2007, and we can see how it's transformed our lives in many ways. So that incumbents must think about how they compete and collaborate with digital giants and collaborate with digital technologies, that every organization has got to think about their future in the digital age, and that most importantly, we've got to break free of our traditional modes of thinking and again, reimagine how we do business. And so we talk about in the digital age that we've got to think about how we automate, how we augment, and how we amplify human capacity. And that it requires, in fact, us to orchestrate new partnerships to co-create new ways of doing business so that we can amplify our abilities and our capacities by better man-machine interface. So at Boston University, we had this digital health initiative, which is really cross-discipline collaborative. And the whole idea is to look at all of the technologies that can be developed to enhance the delivery of healthcare. And we have a large number of projects that are ongoing that look at issues of remote monitoring, use of mobile apps, use of mobile technologies to assess behavioral health changes and depression, and optimizing discharge decisions as well. There's work that's being done in terms of looking at how you can enhance home physical therapy using digital and robotic technologies and data analytics that I think are going to be important. So digital health is with us, and you see the definition of it here. That is the convergence of digital and genomic technologies with health and healthcare. But really, the output of that is that we want to be able to drive to more precision medicine, if you will, making sure, again, that everybody gets the best care that is personalized for them, particularly as you look at the effects of genomics, proteomics, and the like, that we optimize the clinical care, the administrative process. But as important, we also need to change sort of the paradigms in which we train and develop the workforce, so that it's going to be important in terms of using technologies to improve our strategies for education. A few weeks ago, I was asked to give a keynote at one of the major surgical meetings, and I got there early. I sat in the audience, and there was this program just before that was called a Fireside Chat, where a young professional, usually just out of fellowship, would interview a luminary in the field and talk about their career progression. And one of the discussions immediately became, and this fellow was just out of his fellowship, he said, I arrived in the operating room a couple of years ago to work with you, and I was nervous, and I had prepared by reading a book. Now think about it, this is 2019, and the way this individual was preparing to do a complex operation was to read the book the night before. I surveyed a bunch of residents, and the residents tell me that one of the ways that they get sort of information and situational awareness about operations nowadays is to look at YouTube. Okay, but YouTube is this kind of unregulated, you don't know the quality and the like. But it gives you a glimpse into the issues that we need to deal with in terms of sophistication and training and creating sophisticated platforms to include gamification and other technologies that will enhance our ability to teach better and develop practitioners in a more efficient and effective way. But there are a bunch of technologies that are influencing our healthcare space that we're going to have to deal with. And again, we can't deal with it without better man-machine interface because we can't just hold it all in our head. So on one level, in terms of personalizing healthcare, we're going to have to deal with synthetic biology and nanotechnologies and genomics and proteomics. There are researchers right now that are working on, of course, tailored ways of giving chemotherapy that use nanoparticles to deliver, but it only works in certain patients with certain receptors, and so this is a very personalized way of developing that technology. But how would you know as a practitioner what's going to work best unless you were tapped into a data system and a decision-making system that would give you that knowledge information to treat that patient specifically? Virtual reality and augmented reality are going to be very important for not only educating patients but educating providers. Data democratization and blockchain may be a pathway to the personalized health record. So I bet nobody in this audience goes to the bank anymore, but you can get online through your computer and you feel confident that you can move your money around because there are trusted ledgers and trusted business processes that get the right amount of money to the right person, usually with no intrusion from anyone else. Well, why is it so difficult in terms of personalized health information for the patient to be in control and to be able to deliver the right verifiable information to whatever doctor they want? And oh, by the way, if I need a consultation because I've got a rare disease and that person is not in my geographic area, why can't I transfer that information to the West Coast or another country to get that consultation as well? So we've got to reimagine what we're doing in healthcare. Cognitive computing, the whole idea of decision support, is very important and developed in conjunction with artificial intelligence or neural networks to learn what we should be thinking about, or maybe even the way we think, so it can give us back more accurate information, is going to be as important in the future going forward. Some of you may have read this in the newspaper recently, that Amazon now has Alexa that is HIPAA compliant. Well, in many ways, this could be a game changer, because think about your Alexa or your Echo Dot at home. Now, what if we've got an Alexa for healthcare where it can give post-operative instructions, it can monitor medication, how patients take medications, can answer questions that the patient may not think about when they're in your office or at the point of discharge. This could be a true benefit. What we're seeing also is that there are great collaborations that are coming about. So the Center for Healthcare Strategies has now combined with government agencies and the Common Care Alliance group. Common Care Alliance is actually here in Massachusetts, and they're charged with managing the most difficult patients in the Medicaid program here in Massachusetts, which is a $1.2 billion kind of effort, because they're the high-end users, individuals that generally have a chronic disease, maybe a mental health disorder, and it's the complexity of those issues that make them super users, if you will. And the whole idea is to focus on what kinds of technologies will be important to producing more efficient care. Smartphones are ubiquitous. And in fact, even disadvantaged populations use smartphones at a very high level. And so that could be the platform in which we make more effective care. There's already been some studies that have shown that you can actually determine when someone is slipping into depression by the activity on their smartphone, what words they use, who they contact. Now think about a future system in which that kind of good profiling is adjusted so that if someone is slipping into depression, it automatically sends out an alert not only to the physician but to their social network to surround them and support them, what that might do for suicide prevention. Just think about that. Okay, so there are many attempts now to improve healthcare for low income and high super users using these technologies. And the whole idea is thinking in a new way about how you link the right services and the right providers with the right patient customer. And also, using these technologies, you can actually adjust for language, you can adjust for health literacy, and you can use imaginative new techniques to actually give information that will be important in making health decisions. And so this will be important in terms of addressing the social determinants of health in what we call trying to adjust for the nurture versus the nature. Nature is about your genes, right? And there's a lot that's being done to improve our approach to genetic diseases. And you may have heard about sickle cell disease and what they're doing with gene editing, in fact, to help cure that problem. But there's this whole other aspect of nurture about what we do in our lives and what behaviors that we need to modify. So for example, just think about it. If a patient with a chronic disease actually comes to the doctor dutifully 6 times a year and gets that 15-minute visit, there still are 525,000 other minutes when they're living in their communities and working that really influence their health outcomes because of the decisions made there. And how do we get into that space? By looking at social networking, et cetera, to influence the change in behavior. That's the brave new world in the digital age. And of course, for chronic diseases like diabetes, it's almost anachronistic now to have a patient come to your office every month, every 2 months, quarterly, with a log of what their blood pressure is or their blood sugar is. Their A1C is already astronomically high. The horse is out of the barn. When you have glucose monitors that can be connected through the Internet of Medical Things, if you will, and almost get a real-time readout. But more importantly, over time, if we can make sure that using artificial neural networks, you can learn from it, you could actually send the message to the Alexa Echo Dot to tell them how to adjust their insulin so that you are not seeing a patient with a hemoglobin A1C of 9, but you can get better control. So again, the brave new world. Let me just conclude by giving you some examples of how these technologies can be used effectively. When I was the assistant secretary, I sponsored a study by RAND, which looked at the use of centrally assisted collaborative telecare for post-traumatic stress disorder. And we found some interesting things, in fact, that service members receiving centrally assisted collaborative telecare reported significantly larger decreases in their PTSD symptoms. And it turned out that this technique was particularly suited for anxiety-related disorder. And on the one hand, it's interesting. On the other hand, it should have been intuitive. Think about the process of our care. If you've got an anxiety disorder and you've got to get to a counselor, you've got to wake up on time, you've got to get dressed, you've got to get in that car, you've got to drive in traffic, you've got to find a place to park, you've got to try and get up to that appointment on time. It's easy to imagine that you'll waste half of your therapeutic time just settling down before you can get into that therapeutic conversation. However, if you can get up, get your favorite cup of coffee, sit in your comfortable chair and flip on the screen, right, you can probably get into that conversation sooner. So we found very positive effects using telehealth, particularly in certain behavioral health situations. And so the Brave New World also looks at the issue that the home is going to be the first and last line of care. Hospitals turn out to be somewhat dangerous places to be for many situations. And so the issue is, how do we deliver more comprehensive care? How do we deliver more accurate care in a connected, digitally connected system? Johns Hopkins has done some studies which have already shown that care at home, and this is not even with high-end digitally connected systems, show shorter length of stay, lower rates of hospital readmission, use of emergency rooms, and the like. It's interesting that overseas, there are many attempts now at how to, in fact, use digital technologies to enhance the system of care. Overseas, particularly in economically underdeveloped countries, they cannot hope to create and do not want to create the system we have. They cannot train enough providers to recreate the kind of system we have. But they do have smartphones, and using smartphones and more sophisticated platforms will allow less trained workers to deliver more care in rural areas and enhance their ability. This particular scenario shows that in 2008 there was an earthquake which destroyed much of the infrastructure in one part of China. China has a big problem in terms of the issue of the number of healthcare providers versus the population. And so they didn't try to recreate the infrastructure that they had before, but they created mobile systems and digital systems and telehealth connected system and found out that they could deliver more care to more people at a lower price. And so there's going to be a great deal of experimentation that's going to go on in other countries that we're going to need to think about incorporating. In fact, this has been termed reverse innovation. So for 100 years, America has produced the improvements in healthcare and then exported it. Now there are going to be countries that are going to experiment and jump over what we do by leveraging technology, and we're going to have to look carefully at how those digital experiments turn out. So digital is the fourth space in healthcare now. It's that underpinning connected infrastructure that we've got to learn how to leverage. It's going to connect hospitals, clinics, and homes in a very different way. And so let me leave you with this thought, and maybe then we can entertain one or two questions, is the future is digital medicine, including the electronic health record, which is really the low end of technology, if you will, and integrating more real-time data on patients so that we can deliver more comprehensive services more effectively and more efficiently and driving better outcomes. But the challenge really for us is, can we catch up with the educational system? We still have a system that is based on an apprenticeship. It still rewards what one can maintain in terms of memory between their ears. It hasn't incorporated digital technologies as adjuncts to decision making, and it certainly hasn't connected us in a way that we can really understand what any individual patient needs, particularly when they're in their community. So I'm going to stop there and thank you very, very much for the opportunity of speaking this afternoon.
Thank you so much, Dr. Woodson. We can entertain one or two questions right now if anybody has a burning question, but I don't want you to be alarmed because Dr. Woodson is staying with us for the second portion of the symposium. But if anyone has a question now.
Good afternoon, Dr. Woodson. Thanks for a great conversation starter. My name is Kirill Zaidman. I come from DentaQuest. I was at IHI's Leadership Alliance last week, and there was a fabulous conversation about health equity. One of the speakers was from Stanford University, and they're doing a lot of research into computer vision in hospitals, picking up such things as has the physician, sanitized his hands or her hands, have the nurses actually follow the prescribed routine of getting a patient out of bed. Mm-hmm. And one of the questions from the audience, which I think was unresolved, was as these digital technologies, such as artificial intelligence, machine learning, computer vision, et cetera, get used in premier centers, such as the Children's Hospital in Boston, is the technical and the digital divide between community hospitals and academic institutions just getting larger? So I'm thinking Boston Medical Center, for example, and that was the question from the individual. So if you care to comment on kind of how does this apply to the issues of...
That's a great question, and in fact, we didn't have enough time, but there are some folks who have written about the digital technologies. Are they, in fact, important advances, or are we producing new perils, if you will? And so I think that's why we've always got to be aware of how we're developing systems and ensuring that we're using the right technologies that produce the right outcome. The bottom line really is I'm not sure that we can stop it. so that we need to be thoughtful about how we incorporate it and make sure it's rolled out. The point about the smartphone was that we sometimes have a naive impression in thinking that all economically disadvantaged communities are totally without technology, but it may be identifying the right platform to use to get the effect that we want.
So thanks for a wonderful presentation. My name is Don Lee. I'm from Wisconsin. Full disclosure, where EPIC was started. And my question is basically, EPIC is, a lot of Wisconsin doctors talk about EPIC, and it's not, it's just not great. It's like great out of a bunch of not so great EHRs. And where do you have any solution to that? You think anything?
So for the first solution is that we've got to stop thinking about the electronic health record in a very naive way. In other words, the electronic health record really was developed to archive data and for administrative processes. It was never developed as decision support. And many of the initial business models of the companies that developed electronic health records was based upon information block, meaning that they would sell you one instance of their electronic health record software, if you will, and even if you own two hospitals, the two hospitals couldn't talk to each other because that's how they made money. It was a business model. What we've got to do is understand that we've got to push the whole field, and we tried to do that when we promoted the acquisition of the electronic health record for the military health system, which now the VA has accepted, in that one of the requirements was no information block, open APIs, where you could change out modules and then you can, in fact, share information easier. But that's what we've got to push. We've got to push that ability to share information across domains and health systems. The whole idea that health systems should own that data is just nuts. It really is. It really belongs to the patient. So, thank you very much.
Thank you so much. And as I mentioned, Dr. Woodson will still be here, so you'll have a chance to ask more questions in a little while. If you will indulge me for just a moment, we are going to go back on the program and do our Vision Award presentation. So Cynthia Hodge is going to assist me in that presentation, or do it.
Okay. Well, as you saw in the video, we've awarded 2 Vision Awards thus far. And basically the awards are for people that have supported the symposium, not so much just the Reed Scholars, but the symposium. And one individual was visionary in the beginning and secured the funding to make it possible, because you can't do anything without resources. So that individual can really be described as a Renaissance man, a very visionary global leader, and he's one of our own Reed Scholars, our first Reed Scholar to receive the Visionary Award, Dr. Brian Swan.
Giving out awards here if you want to.
I'm so sorry. I have to get my glasses.
Are you going to read it?
Yes. Okay, the Reed Scholars presents to Brian Swan, DDS, MPH, Harvard School of Dental Medicine, the Vision Award in grateful appreciation for your unwavering commitment to and support of the Reed Scholars Annual Health Equity Symposium, May 2019.
Oh, thank you. You want to be in the middle?
Yeah.
I like it between right there. It's right up against your coat, right up, so we can see the lettering right up there. Okay, everybody right this way. Your tie, swing your tie a little straighter.